We do want to welcome you to our second, actually, in our new series of clinical discussions for mental health professionals. I'm Andrea Arts. I am Director of Healthcare Provider Engagement for the National MS Society, here located here in New York City. And actually, Sally Stevens, who's just going to wave real quick if you're on, is Manager of Healthcare Provider Engagement in Ohio. And we're really both so pleased to have all of you on this call. And just a little housekeeping. If you can keep your phone or call on mute, except when you are talking, that helps with background noise. If you come on and your name is not in our chat box, or if you're calling in, really, if you could call or email me later at andrea.arts@nmss.org. So we can know that you were on the call, because we'd like to send you a survey afterwards and to let you know of future calls. That would be great. And we really do encourage, this is supposed to be a discussion, and we want you to all discuss. So we want to hear your questions and comments. If you are able to come up on screen when you're, that would be great. And if not, just let us know you have a question, and we'll move forward with that. So really, we want to hear from all of you. Dr. Smith does not want to just hear himself talk, although we want to hear from him. So let me move forward and introduce our discussion lead today. This is Dr. Evan Smith, who is a clinical psychologist and an assistant professor of physical medicine and rehabilitation at Michigan Medicine. His clinical activity is focused on providing psychological services to persons with traumatic injuries and chronic illness, with a subspecialty focus in psychosocial rehabilitation in persons with multiple sclerosis. Dr. Smith previously served as a co-trainer in the Patient Engagement Program, a comprehensive evidence-based training program that teaches healthcare professionals principles and communication skills that improve patient satisfaction and health outcomes. His academic work focuses on the application of rehabilitation, psychology principles to health outcomes, as well as programmatic development, including enhancement of patient health care, professional relationships, and communications. And I read all of that because actually I think that's all fascinating and so relevant to what we all do and the type of work we all want to do here. So without further ado, I will be quiet, I promise, and we will let Dr. Smith lead.
Thank you so much, Andrea. That was a really nice intro, and I really appreciate the National MS Society inviting me just to kind of lead our discussion today, and I would absolutely second that from Andrea. I think of this as a discussion too. This is a kind of a clinical discussion series where we're going to be having a particular relevant topic where we have some existing literature to learn about, to frame the discussion. And then we really want to hear what everybody's doing around the country to serve our patients with MS, their families, their communities. And Andrea sent me a little bit of a list earlier today about who do we have on the call. And at least of the people that were interested in signing up, there were 18 different states represented. So we really have a wide swath of the country, which is pretty cool. So for today, our conversation will mainly be focused around learning about how to address promoting tolerance for uncertainty in people with MS, and maybe even particularly those with early diagnosis. So my plan is to review this article, to kind of set the stage for a conversation, open it up to any questions, comments that happen. If you have a question or comment that comes up as I'm going through this, we're gonna pause. We should talk about that. And then I've also got some discussion points we can address as we're talking about uncertainty. And with that, as we approach the topic of uncertainty, we can really all appreciate this raised level of tension and uncertainty in our world as we're not only addressing the COVID-19 pandemic, but as the American Psychological Association president, Dr. Sandy Shulman, points out, a pandemic of racism that for too long has been unacknowledged. And as we see in the New England Journal of Medicine recent publication, police violence, racial inequities in COVID-19, and other forms of structural racism are concurrent and compounding public health crises in the United States. And as mental health professionals who understand the inequity of the social determinants of health and serve diverse patients, families, and communities, we are all well positioned to use our privilege for change. We can be allies in addressing this public health crisis. Of course, acknowledging that Black Lives Matter is important, but it's only a start. So, I invite everybody to examine and see how they can leverage their privilege today. And as a group, we might want to think about setting aside some time and holding space for a separate call that specifically targets and addresses this topic and our role in creating equitable change. On this next slide, we've included a couple of helpful resources to support the education that is needed for this change. As one of my colleagues here eloquently said, it comes down to talk, walk, and chalk. So have these conversations in your daily life, even if they're difficult, with the people around you. Take actionable steps and make change in your lane, in your specialty, in your life, and then initiate policy change. I'll just briefly review each of these resources. So the Academics for Black Survival and Wellness, I think this is a really comprehensive resource, and in particular, they are holding a week-long educational training series that happens starting tomorrow, going through next Thursday. And it is full days of training and education. And there are 2 tracks, one for non-Black academics and one for Black academics, so addressing different issues. And the registration for those closed tonight, so I really wanted to point that out. If video learning is more your style, Emmanuel Acho, and I'm sorry, I'm hearing a little bit of feedback. I'm not sure if everybody has their, thank you. And so Emmanuel Acho is a former NFL player. He was an analyst for ESPN. He's recording a webinar series that just started, but they're going to be having more and more, having uncomfortable conversations with a Black man. And he invites other people to join him in a safe space to talk about these issues. Below that, if you like a diversity of learning, this link has resources like books, podcasts, articles, videos, film, social media, resources to take action. It's really comprehensive. But of course, we recognize that everybody has different bandwidth right now. And so we might be able to dedicate 10 minutes, 25 minutes, 45 minutes. And that's what this next link is for, Justice in June. It actually lays out a calendar map for, if you can dedicate 10 minutes a day, it's got a plan for that. If it's 25 minutes, they've got a plan for that, and so on. And then lastly, some educational resources for the next generation children. And I'll leave on this topic for today, just paraphrasing one of my colleagues here in the Department of Physical Medicine and Rehab, Dr. Okunlami, who on a recent Grand Rounds was addressing about 10,000 people virtually, and paraphrasing said, it may not be your fault that we're here right now, but in 10 years it will be. So let's get to work. I really appreciate the National MS Society for providing this platform and for engaging providers in these conversations. We really hope to amplify diverse voices in the future. And with that said, I see that there might be some chat box. Is there anything in there that I need to address?
Not yet. I think it's mostly welcome, and my letting everyone know that we'll send them these slides and all the resources after the call. So
okay, super.
So that they can have them.
All right, thanks, Andrea. Okay, so So the article for today's conversation is called Pilot Intervention to Promote Tolerance for Uncertainty in Early MS. And this is by Ivan Moulton and his colleagues at the University of Washington. Intolerance of uncertainty is a personality construct described as beliefs about the necessity of being certain, about the capacity to cope with unpredictable change, and about adequate functioning in situations that are inherently ambiguous. Intolerance of uncertainty has been shown to be a vulnerability factor for anxiety and depression. And as far as I could see, this concept initially emerged out of the GAD and OCD literature in the late 90s, but has more recently been looked at as a potential transdiagnostic mechanism of action that underlies and drives various symptom presentations, including anxiety and depression. As a psychological construct, uncertainty itself can be defined as a cognitive state occurring when the probability of a future occurrence is unknown, and thus the perceived consequences of making the wrong decision are amplified. So therefore, reducing uncertainty can be adaptive, as one may perceive having greater control over the potential outcomes. As humans, we overwhelmingly find it unpleasant to have uncertainty in our lives. However, there is some evidence that shows that some people are better able to cope with uncertainty than others. Those who are high in intolerance of uncertainty may attempt to reduce that uncertainty by attempting to gather information even when it's not possible or when it's unproductive. I think we've all ran into people who religiously search the internet for answers even when there are no good answers. But the internet told me this. So while there have been some CBT and mindfulness trials that have been shown to reduce intolerance of uncertainty as a secondary effect, that's really promising. Conversely, we have tolerance to uncertainty, and we think of this as being a protective factor for positive psychological adjustment in people who live with MS. As many of you on the call know who work with people with MS, those who are newly diagnosed are forced to confront an uncertainty, both in navigating the disease itself and in coping with the chronic uncertainty about how function might change and how this could potentially impact quality of life over time. However, the majority of care early after an initial diagnosis of MS focuses on patient education and disease management, rather than on providing or enhancing skills to manage worry about this uncertain future. And up until this study, a few, if any, publications had addressed interventions targeted specifically to enhance tolerance to uncertainty in medical populations such as MS. So Moulton and his colleagues developed and analyzed the outcomes following a 6-session intervention, which is very brief, in people with less than 3 years post initial diagnosis of MS. And this intervention group, was compared to treatment as usual. Their primary outcomes were intolerance of uncertainty, mood, anxiety, and MS acceptance. So being a pilot study, they enrolled ultimately 48 patients who were primarily Caucasian, primarily women, well-educated, on average about 38 years old, and on average had lived with MS for just over about a year. And these demographics were found to be consistent with individuals with early MS in the United States. Now, the intervention itself focused on understanding the difference between aspects of MS that were knowable versus unknowable, understanding those aspects that can and cannot be controlled, learning to tolerate not knowing exactly what the future will hold, setting personal goals for accepting MS despite its uncertainty, practicing mindfulness, and finding ways to live in conjunction with one's personal values despite the uncertainty of the future. One really helpful part of this pilot intervention was that it allowed patients or participants to self-select whether they wanted to do this treatment in person, on the phone, or a combination of both. So they recognized that not everybody has the bandwidth to to participate in psychotherapy in this way. So they developed a really brief intervention in a way that meets people where they're at, in person, on the phone, or both. Ultimately, they measured satisfaction with the intervention. They measured intolerance of uncertainty using the intolerance of uncertainty scale. They measured MS acceptance using the acceptance of chronic health conditions MS version. And they measured global anxiety using the GAD-7. So the authors found that the intervention was very well tolerated, with most participants, about a little over 82%, completing all 6 sessions. And following the intervention, on average, with moderate effect sizes, those in the intervention group demonstrated lower levels of intolerance to uncertainty and more MS acceptance compared to those just receiving treatment as usual. Decreases in intolerance of uncertainty were associated with increases in MS acceptance. There were no significant effects on global anxiety. Now, in the article, I think they gave some really nice quotes from some of the patients that completed the intervention arm. And I want to read a few of them because I think it gives a nice qualitative understanding of how they perceive their experience. So one participant reported, after the 6 sessions, I feel more able to experience negative feelings and thoughts, especially about MS, and I'm not afraid of being consumed by them. Another participant expressed something similar. Knowing it's okay to have the thoughts I have about MS, but at the same time, not allowing the thoughts to be any more than that, a thought that probably can't be answered and won't be in this life. And that's okay. I can just let the thought go and move on. And finally, one last participant shared, I'm able to look at my health struggles with a new perspective, one that doesn't judge, which helps me to lower my anxiety. So overall, the 6-session intervention was well tolerated and demonstrated that intolerance of uncertainty is responsive to a brief psychological intervention. Improved tolerance to uncertainty is associated with positive psychological outcomes. And ultimately, and I think what makes it relevant for our call, is that psychological practitioners who work with people with MS should consider the ways that the client's disposition to tolerate uncertainty interacts with this unpredictability of the disease of MS, and consider intolerance of uncertainty as a key transdiagnostic treatment target in psychotherapy. So that's a bit of an overview of the article. And I'll just take a quick pause here. Andrea, is there anything, any questions, any comments that came up? All right.
Yeah.
So go ahead.
No, I was just going to ask if there are any questions that aren't written in yet.
Okay.
Because, no? Okay.
Okay.
Not yet.
Having trouble advancing the slides. 1 second. There we go.
Mm-hmm.
Okay, so I chose this article for a couple of different reasons. I think that having one key construct that may be transdiagnostic is potentially a really powerful target for treatment. So tolerance of uncertainty may be an important transdiagnostic protective factor for adjustment. And for those recently diagnosed with MS, we know that the future is uncertain. So I think that all of us have encountered this in maybe some ways. Maybe we didn't have a name for it. Maybe we didn't know how to educate our teams that work with our patients with MS in how they can help them to better cope from the outset and focus not only on the education about MS, the family support around MS, but also how does one get hooked up with a mental health professional to help guide them, even briefly, in becoming more comfortable with discomfort. And all of this seems to be compounded by a global level of uncertainty right now, as we are all living through a pandemic. even people who don't have MS have varying levels of uncertainty and tolerance to that. So these may compound based on one's disposition. If they're naturally tolerant of uncertainty, maybe they're coping better with what is a higher level of tension and anxiety these days. If not, maybe that's something that we need to consider. By cultivating a tolerance of uncertainty, we can ultimately empower people with MS to live well. And when I was doing a little bit of research for this presentation, I found a blog post that was titled "Living with Uncertainty is an MS Superpower." And sometimes I've been meeting with folks who are telling me that, yeah, the pandemic is stressful, but my life isn't really all that changed. And I deal with uncertainty every day. This is not new for me. So I think if we can cultivate that asset and enhance it, and you know, we can even look to people who cope well as leaders. And sometimes I pose that to patients sort of paradoxically. So those are kind of the reasons why I chose this article. And I can open it up to maybe some more discussion points. I have some here, but if there are any questions, comments, thoughts, how are people addressing this in their own clinics? Or I can just kind of go through this list of discussion points. Andrea, what do you think would be best?
Why don't we open it up? I think these are great discussion points, and I did send these out earlier to most people who had registered so that they could think about them. But I think there are, I'm sure, other ones also. So let's open it up to people, if that's okay.
Super.
Well, I'll start.
And,
or there's someone else.
I
see. I have Kim and maybe Kelly. Did you unmute yourself?
Yeah.
Because you have a great. So.
Yeah, I have some. This is Kimberly. When you're ready for me, it's kind of weird because now I'm on my phone, so I can't really type very well on my phone.
Okay, so don't fight. Why don't we let Kelly go first, and then we'll get back to you, and then we'll go to you, Kim, and then we'll kind of keep. I'll keep a stack.
Sounds good.
So, Kelly? We're not hearing you. Let me try.
How about?
Hold on.
Can you hear me now?
Yes.
Oh, interesting. So there are two buttons for mute. Learning things all the time. So hi, I'm Kelly Garrett. I'm a neuropsychologist with Rocky Mountain MS Clinic in Salt Lake City, Utah. One of the things that I like about this particular framework is that it's non-pathologizing. It's not like you have anxiety and we need to fix the problem with your anxiety that's causing functional disability or whatever, right? I mean, just think about the weight of all of those terms and those words. And I think uncertainty tolerance is something that, you know, really every human has to deal with. And the positivity that can be engendered in this approach, I think, is huge. I think it has the potential to really break down some access barriers as well. I think people would be more likely to be engaged in this type of work rather than going to maybe a traditional CBT approach or ACT approach. I just think it has a lot of potential to resonate with people.
I don't know whether you want to comment or do you want to just Evan or?
Yeah, no, I
think
those are some phenomenal points, and I think by normalizing this experience as being human, if anyone was faced with this, they would be experiencing some level of discomfort with uncertainty. Everybody's got their own varying level of disposition that they come into MS with. So we want to treat that whole person. I think someone else is also trying to comment.
Well, that's Kim. Kim, right before I get to you, I just want to say that there's a comment in the chat box from Dr. Meg Tippy that she's seen the same in families with cancer, that they're good at infection precautions and isolation. And so many are faring quite well with the current restrictions. So both learning are ready to deal with uncertainty, but also the pandemic has normalized what's normal for them. And actually, I've heard that from some MS patients who can't get out a lot, maybe because of their physical disabilities, that suddenly they feel like, aha, now you all know what it feels like for me. And that everyone's uncertainty and change sort of makes them feel like they're the experts in some ways now. Let me next get to Kim, and then I'm not seeing. Oh, that's Dr. Tippy. Did you want to say something more, Meg, about what you wrote in the box?
No, because you actually summarized it beautifully. The piece where finally the world may be in a place to understand and appreciate what it is like to have medical frailty and how complicated the world can be, and how it's not just so easy to, well, you just stay home, that sounds nice, or how complicated it can be to do something like go to the grocery store with precautions, etc. So.
Okay. No, that's an excellent point, really, that I've heard too. I have Kim and then Ronnie. Kim, you're on.
Okay, so now just a comment, and then I'll go to the article. So I just really want to echo what Dr. Tippy and I think it was Kelly was saying, the sort of normalizing that is occurring with people who live with medical illnesses in this international pandemic. So many, I work in a rehab setting as well, and so many of the patients and the clients are sharing that now, in a way, they feel like they're part of society because society understands a little bit more what it's like to live their lifestyle. So that's one thought. But with regards to the article, when I was listening to Evan and then also looking in the article at the intervention outline, what came to mind to me is so some of the words that were already used: non-pathologizing, normalizing, but motivational interviewing, the crossovers with motivational interviewing and positive psychology that seem to be maybe at the foundation potentially of this it looks like a 6-session model. And I think on the last call a couple months ago, we were talking about this concept of meeting someone where they're at. So it's just really refreshing to see that different researchers and clinicians are out there looking at creative ways to meet individuals where they're at.
I think that's, really such a good thought, Kim, and particularly, I think to both the normalization piece and also seeing these issues as important as other parts of disease management, that being able to manage your ability to manage and all the things that come. It also seems to fit with me with a lot of the focus on resilience that we've been reading, because I would think that a key part of resilience is dealing with uncertainty.
Yeah.
and all of that it brings.
Well, yeah, so I was thinking too, what resilience came to me as well. Resilience and tolerance, and how there's crossover and how they're different. I don't know if anybody else wants to speak to that or just leave it at that.
Okay. Ronnie?
Yeah, I just wanted to go back to something that you were saying, Andrea. And, you know, I also with my MS support group, and then also my work with individuals that are bereaving a loss. And, you know, I did hear early on this, like, you know, now with COVID, you know, other people are really experiencing this level of uncertainty that I've experienced for a good while, and kind of that, I know that, and like now people are feeling what I feel. But what I found is in my support group around the racism pandemic, that there was this other level of, and the word that came up in the group was despair. You know, that you know, it feels a little like, to me, complicated uncertainty. You know, we talk about complicated grief, and it felt like there was this rise of complicated uncertainty, and really sitting with so many emotions that were hard to tease out of having MS, staying in because of COVID and living life differently, but sort of getting like people now know how they live, but now subjected to another level of uncertainty that's really systemic and we're all facing. And so it kind of came at, it was like a thread throughout. And I think we were really just sort of sitting with all of the feelings and reminding ourselves about using, you know, grounding techniques and mindfulness and really being able to sit with. But this level of despair was something that I really noticed as a shift, and wondering if that will, you know, if that resonates for people in your work with patients, people that normally were doing fine enough.
Does anyone want to talk to that, to an added level of despair? I know, I see, Alicia, that you would like to say something about caregivers at you know, at the VA.
Yeah. Hi, everyone. I'm Alicia Sloan. I work at the VA in the Puget Sound area, Seattle and Lakewood. This conversation is making me think of one veteran in particular and his caregiver, and how hard it is that he's finally accepting, he's having possibly other things going on too. He's in his 70s, and he may also have dementia on top of the MS, and he had a big fear of, and there was this conversation going where he's really needing long-term care, and looking at the Soldiers Home here in Washington State, and how the grief that he's feeling and the uncertainty, especially with COVID, he's, you know, afraid to go to a nursing home because, you know, what if he gets COVID? And one of the Soldiers Home that he's looking at has actually been able to avoid any COVID in the nursing home, in the Soldiers Home. So that was a good thing. But it was really kind of going to where he was. And one thing I noticed is, like with his caregiver and with other providers, we were always talking to the caregiver. And so I thought, I'm going to talk to him and see how he's feeling about all this. And he he was definitely in some despair, and had a lot of fear, and just kind of meeting him where he was at and talking to him about how he was feeling, and then talking about those fears that he has. And it was kind of it was a hard conversation for him because he's not used to really articulating his feelings. He's often kind of the strong, silent type. He's also been having some behavioral issues, like he would pee inappropriately, and doing a lot of, bowel bladder issues, and his wife and his family were trying to help him, and he would refuse to use the bathroom and go on the floor. So he was having some interesting behavioral reactions at home. But I noticed that once he and I talked, that he had he was moving more towards, I understand why I need higher level of care. I understand it's too much for my wife and my family to help to care, take care of me, and I really should go to the nursing home. And this article kind of affirmed kind of what I had been doing with talking with him. And then I have another veteran who has COVID and he's homeless, and he's a younger fellow who he may have some bipolar and PTSD as well. But it was interesting his MS symptoms are increasing. He's having a lot more fatigue, and he'd had to deal with having COVID and being isolated in a hotel, and now the homeless program is trying to find him housing. But he was talking about how his life is so uncertain, he doesn't know, and he gets overwhelmed easily. And so, like with him, I just kind of said, okay, let's just take things one step at a time and address different issues, and I'll walk you through these things. And he said, wow, that's the first time anyone has ever just kind of gone through things step by step. And because he was so overwhelmed by all the different, social workers and seeing this physician and that physician and trying to figure out, telehealth. And so it kind of comes back to what this article is addressing. And a lot of them also, and then on the flip side, I've had a lot of veterans say, oh, it's no big deal. I'm used to isolating and staying away from people, so some of them are coping quite well and remarkably well, which I was happily surprised. And some of the caregivers, some of them are coping pretty well, but some of them are experiencing more burden because they have to, kind of plan ahead a little bit, go shopping at certain times. They're being super careful about trying not to, wearing masks and when they go out. And so it's interesting talking to and hearing the different reactions. But I like this article, though. It's helpful.
Okay. Kelly, are you unmuted so you can say something else?
Let's see. Can you hear me now?
Yes.
Okay. So there were two things in the article that I wanted to see but weren't presented. One, although I appreciate that one of the outcome measures was MS acceptance, I'd like to know how this intervention would impact self-efficacy, perhaps general self-efficacy, but also MS self-efficacy as well. I actually would rank MS self-efficacy as being a more important conceptual concept that we would want to try and bolster within rather than acceptance, because with that self-efficacy, you know, we're going to see a lot of great halo effects, like, you know, improved health literacy, maybe, you know, improved so-called adherence, and other aspects. Another thing, and I appreciate that this is a pilot study, but another thing that I had wanted to know about was just a brief sense of what the trauma history or the trauma burden may have been amongst these patients. And you know, one can experience trauma in a couple of different ways. For way too many, that can mean something that happens in development, which I find very, you know, shockingly common with women with MS. But also, you know, some develop, you know, their introduction, if you will, to MS is a very acute, intense experience that might land them in the emergency department, perhaps with an ICU stay. And so it's sort of MS-related trauma, which is not good for uncertainty tolerance. And in fact, you know, may really exacerbate or kind of set people back. And so knowing kind of what that trauma baseline is in some kind of a quantifiable, you know, easy metric, I think would be helpful. I'm also you know, not only from a scientific standpoint to see, okay, were the basically no contact control and the intervention group, like, were they balanced in terms of the trauma? But also one could hypothesize that that level of, that the intervention of uncertainty tolerance may play out differently amongst, you know, a low trauma group of patients versus a history of high or significant trauma group of patients. So if anybody's thinking of planning a follow-up study, there's my vote for a couple more measures to dump onto the whiteboard.
Those are some really excellent points, and you know, as I was reading that, I did not consider that, and I'm wondering if, you know, in hearing the way you describe it, it almost fits into that everybody comes into MS with some level of experience and some level of disposition that might be informed by, you know, non-MS related traumas, like you were saying, which are shockingly common. I wonder if, I haven't looked this up, but do you know if there's like an MS specific trauma scale that we could be, this is not my study, but it would be nice to know. That's, if there was such a good point. And yeah, so thank you for that.
Yeah, that's a good thought.
I kind of liked,
or Evan, just to if I could just piggyback on that, maybe
please.
not even necessarily MS related trauma, but just like hospitalization related trauma, or you know, even we've all heard, even in the ambulatory outpatient setting, there can be some things that hit the level of trauma too. I'm not sure there's anything. People can argue this point, but I'm not sure that there's something really special about MS in that kind of trauma that wouldn't, you know, kind of generalize to other types of, say, ICU trauma. So I would, many times I meet with patients and it's taking them
maybe even years to have gotten an actual diagnosis of MS, and that process itself can in and of itself be demoralizing and perhaps traumatizing. What I really like about this approach, particularly with people who have who are early in their diagnosis, is that if we can connect them to these resources and they begin to learn these skills around resilience early, we may be able to set them on a different trajectory, and they may be able to engage in these coping skills, rehearse them for longer periods of time, so that later on, when we've got the people who are later stage, they already know what to do with that. They've been living with that. They've been living with coping for a long time. Just in my setting, it's an academic medical setting, and there are times when I meet with people, and it's just we've done everything else. Can you go and see this person? Or it's now that I've had an opportunity to give some education to the neurologist there, they are including psychology a little bit earlier on. And I'm wondering what other people have found in working with teams. Are there facilitators to getting engaged early with patients who have early diagnosis? Are there barriers that you're finding? What's worked, what hasn't worked?
Meg, I see you are unmuted, so I didn't know if you had a.
I popped in relation to the prior question, popped my face on in relation to the prior question. I screen all clients for adverse childhood experiences, and ACEs is a big buzzword. Lots of people doing training. The trainings are free. The measures are accessible. I find the information somewhat useful, but it's stuff I would have gotten in a clinical conversation anyway. But what I am finding is that it really launches the conversation around how common shitty stuff in childhood is in everyone's lives, and then allows the conversation to move to other traumas that maybe, like, if we don't talk about that, we don't talk so much in society about, for example, how hard it is to see 9 different doctors who dismissed what your symptoms, et cetera. So if the screening is useful for the number, but it's much more useful to launch conversations. And now that you're also talking about how to get things moving a little bit more in a psychological way within big, like, medical centers, et cetera, I wonder if those screenings might help the teams understand just people's lives and the impacts of difficult experiences that are actually quite common.
Mm-hmm. Anyone else want to speak to this or have thoughts about this in your own practices or facilities?
Andrea, I want to add that we've got
I do
8 minutes left till the top of the hour.
Okay, so good. Great. Just to keep us sort of knowing where we are. I just wanted to add 2 thoughts. One is that certainly always, particularly for those who work in interdisciplinary teams or in medical centers, or those who work outside of them but see patients or feel that there are patients that could make use of work in these areas earlier, always trying to find ways to help others understand that these issues are important and the skills are important. Because I totally agree that I was thinking that after the 6 weeks, probably a lot of patients could use boosters as things change, because because as we know, with each change comes sort of a new uncertainty to grapple with, and sometimes it's not always generalized, or you need practice, or you need to be able to look at it with somebody else's perspective again. to help you see that it's sort of the same skills can help you. And I could see that sort of happening along the way. And I was actually, the other thought I was, when I was listening to Ronnie, when I was thinking about the extra despair that our patients are maybe feeling right now, not to mention a lot of us, even with those without MS, is that how the common thread for me when we're thinking about MS, if we're thinking about COVID and even racism at this point, is although we see the results, whether it be in progression or increased disability, or when you're suddenly sick, or you see the results of what happens with racism, there's an invisibility of it, that it's around us and in us, and we don't even know until it's suddenly there, or we're seeing the results, and how that's lack of sense of control, or not knowing, and suddenly people are looking, am I racist? And what do I do, that is racist, or it's part of our whole culture, or our symptoms and all of that. And that, just like with MS, it's happening inside me, even, to some extent, whether I know it's happening, and certainly with COVID. So I was thinking that has this extra level of despair. And then the other common link for me was why I was thinking of both of them for our patients is that beyond the internal work and fear is that each of them need this ability to care for others as much as ourselves, and to allow others to care for us, whether it's as you're having to trust your doctors, your spouses, your family to help you. And with COVID, there's a lot of trust that has to be in there, as we're also wearing our masks and everything else, not just for us, for everyone else. And it's the same with what's going on around us with racism, that there's suddenly, it's not just us, it's beyond us. And I think I'm wondering if that feels overwhelming to our patients also, both of those pieces, that it feels like this triple kind of whammy.
Can I add a piece to what you're saying with the invisibility piece? I think there also, certainly early on in COVID, was a piece around, which is not uncommon with somebody with MS feeling disregarded or put aside medically, that suddenly needed medications were going to be less available because they were being filtered to people with COVID. And there were some states where people were talking about needing to make decisions about who they would treat based on if you already had underlying conditions. And so someone with MS is not considered as whole in those decisions. And that may be still happening in some places, but that seems very painful.
Kim, did you want to add something to this?
Yeah, I'm aware of the time. So here's my thought, is that as I look at the intervention outline, and there were a few things that you were just saying, Andrea, that all of these things, mindfulness and thought awareness, managing the need for control, acceptance and integration, living with values, these can be very vulnerable topics to explore. I started to think about, like, what is if we use the word vulnerability, or the depth that individuals are willing to go to. And this applies to all of us, right? With MS, with COVID, what's your ability of awareness of self and other? So, the study and this topic that Evan brought to us, it really opens up the conversation for a lot of areas.
Yeah, definitely, definitely. I see many topics of future meetings. Mhm. I'm aware we only have about 2 minutes. Evan, do you want to, and I know this is the beginning of many discussions and not the end. And actually, I think I saw you, Kelly, but I think we have 2 minutes. Do you want to make a quick comment, or should we?
Yeah. If I could, regarding number 5, I'm wondering about just a quick read and feedback from this book regarding whether you think the intervention could be adapted to an online class. I mention this because we have quarterly 6-week classes on, therapeutic writing, managing physical symptoms. We've adapted the MS Society Science of Happiness curriculum. And when I saw that outline that said, 6 weeks, boom, 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 I was thinking, wow, wouldn't this be great as a class? But keeping in mind that this would not be a one-to-one interaction. This would be, a little didactic, a little discussion, a little camaraderie kind of a thing. So any thoughts, any volunteers of those that might want to come join our faculty for these quarterly classes? What do y'all think?
I'm open to it. Love to hear some more information on it. That sounds great.
Yeah, pretty amazing. It sounds like a wellness approach. And
Evan, I don't know if you have any final words.
Just in the last couple of seconds here, I wanted to provide a few, just some resources that I know I found helpful, not only in relation to learning more about intolerance of uncertainty, a couple of articles there, but generally, here are some resources that I find helpful, some of which are passive. If you sign up for MS News Today, you get the highlights of content sent to you every day without having to do anything. You can delete it if it doesn't look interesting. If it does, you can click further. I think these webinars that Can Do MS offers have been really nice. I usually will provide the patients and their families at least with the access to this information, and they can do with it what they want. And then John Strum runs the Real Talk MS podcast, and he goes in depth with experts around the country. He's got his own experiences in being a caregiver to someone with MS, and so I think he's a really helpful voice in this sphere. And I will just click to our next one here.
Right. Yeah, so right now we are scheduled for our next call on Thursday, August 20th, from 2 to 3 p.m., the same time. We're generally going every other month, the third Thursday of the month. And the registration link. We are going to send you all a brief survey so that you really can help us get some feedback about this call, but also with ideas for future calls. And I don't know, I mean, originally we were wondering, our steering committee and Evan, whether people might want an additional call to be talking about some of what's going on for our patients sort of in a month instead of our regular other month. You can let us know that either in email or in the survey if you think that would be useful given just all that's going on for us right now. I really thank you all for being on the call. I really want to hear your thoughts. Look out for the survey. It's really important to us. And we will also send you the slides that have all the resources on them. And I think that's really it for now. Thank you for your participation. Really, it's definitely much better when this is a discussion. And Dr. Smith, any final words?
No, I have to echo that. Thank you so much for your participation. I've learned a lot today. I really appreciate seeing some of the faces on here. we can create a community of providers, I think, with these types of calls, and looking forward to the next one.
Yeah, and thank you, Evan, for this wonderful paper and this great discussion topic. It really, thank you for the time you spent to put it together. It was great. And on that note, off we go.